Okay. Okay, thanks everybody for joining. We're going to wait a second while folks all get settled, and then we'll get started.
Cannot hear you.
Now you can hear me, can't you?
Yeah, now I can.
So now we're really going to get started. Thanks everyone for joining us today. I'm Christy Giuliano, Executive Director of the Big Cities Health Coalition. BCHC is a forum for the leaders of America's largest metropolitan health departments to exchange strategies and jointly address issues to protect and promote the health and safety of the nearly 62 million people they serve. So we'll get started in just a minute. We're going to do a few housekeeping issues, announcements. If we can go to the next slide. So this session is being recorded. All of the lines are muted except for the speakers. If you're having any technical difficulties, you can raise your hand. You can also chat Gabrielle Nichols in the chat if you have any technical difficulties again. And then after we go through some questions, we'll take questions from those of you on the line, which we'll do through the chat function. So you can go ahead and put your questions in throughout the discussion, and then we'll queue them up for later on. So Gabby, let's go to the next slide. I'm going to introduce our speakers. So Dr. Sara Cody is the County Health Officer for the County of Santa Clara and the Director of the County Health Department. In her role as Health Officer, Dr. Cody's duties include providing public health leadership for the county, including leading the development of public health policy and programs, assessing and responding on the health status of the community, and enforcing local health orders and ordinances, which she's been doing a lot of recently. She holds a medical degree from Yale, completed her residency at Stanford, and also did a 2-year fellowship in epidemiology and public health as part of the Epidemic Intelligence Service, or EIS officer at CDC. She's also the current chair of the Big Cities Health Coalition. Dr. Tomás Aragón is the health officer of the City and County of San Francisco and the director of the Population Health Division at the San Francisco Department of Public Health. As health officer, he exercises leadership and legal authority to protect and improve the population health and health equity. And as director of the Population Health Division, he directs public health services for San Francisco. He holds an MD and an MPH from Harvard, a DRPH from UC Berkeley, and completed his clinical and research training at UCSF. Tomás is a former chair of the Big Cities Health Coalition. So thank you both for being here today. You know, we were chatting just as we were getting started, and everybody's running from one call to another. So we really do appreciate your time. So Sara, let's start with you. So the Bay Area has been held up as a real leader in the COVID-19 pandemic response due to your early and aggressive work to slow the spread. Can you tell us a little bit about the early days? What factors went into your decisions? What enabled you to be somewhat more aggressive than perhaps some other areas? And, you know, how did you all work together? You sit on opposite sides of the Bay Area or across the Bay, clearly not from California, but what did that look like? And tell us a little bit about, again, those early days.
Oh, Sara, I think you're on mute.
Okay, now you're unmuted.
Uh-oh, am I unmuted now?
Yep.
Okay, thank you. I'll start, and then of course I want Tomás to chime in. So first of all, we're just down the peninsula from Tomás. So Tomás is at the top of the San Francisco Bay Area Peninsula, and we're down in the South Bay at the bottom, and there's one county in between us, but we're really part of a region. And so, I mean, I think there's a couple things. One is in California, under the law, health officers have quite a bit of authority to act, and that's both a blessing and a curse. So we have a lot of responsibility and a lot of authority to make decisions based on what we think is best for the health of the communities that we serve. So I think just structurally, that's a little bit different here than it is in many places, and in this regard, that was helpful. I think another just, you know, in a very personal way, I've worked with Tomás for a very long time. When I was still training, Tomás was already practicing public health in San Francisco. And so I have looked at Tomás for advice for over 2 decades. So that was also a very helpful, that's just important context to know about how we acted. And the third is that Santa Clara County saw some of the earliest cases and earliest activity in the epidemic in the United States. So we both anticipated that we might have activity early just based on our experience with SARS, based on the demographics of our population and our travel patterns. So much travel for both personal reasons. Many people in our community have family and friends all over the world, and as well as professionally. Silicon Valley just has a lot of travel, particularly to Asia, much like the Seattle area. So we were thinking and actually worrying early on. So we had a little bit of a lead time in the thinking and worrying. So that's just that's the background. And I think during the early days, we were communicating frequently as a broader Bay Area group, trying to take guidance and put it into and implement it in the Bay Area. I'm just going to hand it back to Tomás for your thoughts on those early days.
Yeah. So for me, it was really an evolution of a process. And I can still remember on some of our early calls with Sara, where some of us were saying, "Oh yes, you know, following travelers and doing the quarantine. That were you know, if those early PUIs are being negative, everything's fine because the highest risk was from people who are coming back from impacted areas." And I remember Sara saying, "You know what? I know it's circulating in the community." So Sara really had this early intuition. That it was circulating in the community silent. Some of us were skeptical, and I think to me that was part of what makes our collaboration successful. It's just the cognitive diversity, the real difference in thoughts, our ability to be honest with each other, to have candor, and for us to be able to disagree, agree to disagree, but we learn from each other and you know begin to develop a shared understanding. So I think for me that's been really positive. I do want to say that one of the things that happens is that as we moved forward, as decisions were being made, and I would say Sara took the first big step. I remember her when they said you cannot have events over 1,000, and she shut down the San Jose Sharks. and we're saying, it's like our heads are spinning and we're saying, wow, that's a big step. We had only made recommendations, and of course people don't follow recommendations. So she took that first big step, and then we followed, and then she took another big step, and then we followed, and then San Mateo even took a bigger step than either of us. So it was really that cadence of changes that I think sort of prepared us mentally and politically. And then I want to add a couple more things, and that is, one of the things I recognize is that as we were taking these big steps in San Francisco, there was a tremendous amount of political support for what we were doing. And in fact, they were ahead of us. The Board of Supervisors were saying, you need to do more, you need to do more. And I reflected as to why that is. And I think one of the reasons is that in the Bay Area, I think people were really attuned to what was happening in China, in Italy, and people were seeing that, and they wanted to make sure that that didn't happen in San Francisco. And then my last thing I want to mention is that in terms of decision making, the fact that we were able to really come together, be honest with each other, have candor, be able to disagree, that we were able to build a shared understanding and converge towards a consensus. And I think for me, that's a really core principle in terms of decision making, the ability to do that. One of the challenges with decision making is that a good decision making process doesn't mean that you're going to have a good outcome. People judge our decisions based on outcomes. And I think this is where it's really challenging, because one of the reasons why the Bay Area looks good is that we have counterfactuals to point to. So we can look at other areas and say, oh, whether or not they had a good decision making, they may have had a tremendous decision making process, but you see different outcomes occurring. So without those counterfactuals, the Bay Area doesn't necessarily look better than other places. If other places did not have some of these other outcomes that are worse, we would not necessarily look any better than anybody else. So I want to point that out, that we have we end up being judged primarily by outcomes, and what's happening in the other areas helps us see that alternative world and what decisions can lead to.
So thanks, Tomás.
Go ahead.
Something else I just wanted to add, thinking back to the process of making that decision, is it was in that we were going in a stepwise fashion from banning, mass gatherings to banning gatherings of a smaller size, and we were in some ways, inching our way towards shelter in place, and that was important, not just for the public, but I remember that was important for me personally. I mean, I was thinking back to March 13th when we banned gatherings greater than 100 or greater than 35 without specific measures in place. I remember talking to the press and talking to the public that day, and I actually choked up and thought I was going to burst into tears on TV because I was thinking about, wow, that's like so extreme to not let people gather. And that was on a Friday. And then all of the sort of cognitive and psychological work that happened over the next 48 hours to get us to the place where we were ordering shelter in place. And I think just for me personally, to get from that Friday to that Monday wouldn't have been possible without like iterative conversations with people that I really trust, because I wanted, you just want to really check your decisions and make sure that they're solid ones. And we had relationships. I just cannot overstate the importance of long-standing working relationships for all of us being able to make decisions. Back to you.
So, like many big cities, urban areas, large counties, your jurisdictions are incredibly diverse. Multiple languages, race and ethnicity. How does that affect sort of what you do, both in the response and then in thinking about, the future, and what factors have you had to consider, and, what conversations have you had with each other and your teams in thinking through those differences?
Sarah, do you want to go first?
So,
go ahead.
Okay, I'll start. So at the beginning, we spent quite a bit of, at the beginning, what we were seeing on the ground was more harm from discrimination than we were seeing harms from the virus. So our community is almost about a third Asian, various different Asian subpopulations. And we were seeing all types of discrimination showing up in all types of different ways. And that was like a really core area of work for the communications team to think through together with community partners, what could we do, because it felt so much more harmful and was more harmful at that time than anything we could see with COVID. And then things have changed over time. And now I think our biggest challenge is trying to both understand and help with the disproportionate of both COVID-19 and shelter in place among some particularly vulnerable communities. And so areas of our county where we see health disparities, and any kind of health data that you look at, you see the health disparities in particular communities, and we're seeing it with COVID-19 as well. But figuring out how to address that and actually be helpful is incredibly complicated because there's so many layers. There's distrust of government as just sort of a core underlying everything. And so we really can't make good decisions, I think, unless we rely on the community and community leaders to help tell us, we can say, this is what we're trying to get done, or this is what we're worried about, but we really can't make good solid plans unless we work carefully through our community relationships, and that also takes time and care. So I think we are now seeing disproportionate impacts both from COVID and from shelter in place in the same communities.
Yeah, so that's really a good question. So I feel that San Francisco dodged the bullet. But when we look at the vulnerabilities that exist, so for us, it's been, and this is true across the country, which is going to be long-term care facilities, SROs, persons experiencing homelessness, people that live in crowded conditions, and then the jails. And we noted early on, for example, that we were seeing a lot of cases in Latino workers. So San Francisco General Hospital, almost 80% of the cases there are Latino. And so there is just a tremendous amount of transmission happening, especially among the workforce. And we just, with UCSF, completed a surveillance study in one of the neighborhoods that's predominantly Latino. And the prevalence among workers was 6% active infection, which is really high when you think about it. In the general community, it was about 2%. And so we don't know what proportion of them have already been infected, but there is just a tremendous amount of crowding, language issues, immigration, cultural issues. And that's just one group. And then we have, of course, other ethnic groups that have, it's different with every group. And I would say right now, that's our biggest vulnerability in San Francisco. So we have 500 SROs, close to 20,000 people who live in really crowded conditions, multi-generational families living in rooms, sharing kitchens, sharing bathrooms. So it's a humongous challenge of how we're going to address that. And we're reaching the point that we're now beginning to do mass screenings. So we're doing mass screenings in the shelters. When we have cases in SROs, we're beginning to do screening in the SROs. And it's a big strain on the public health workforce to be able to do all that, the field teams that have to go out there. And I think that's what we have to build out more. We have to build out more of that capacity to be able to put out the outbreaks that are happening and to be able to prevent them from happening. Because I think we've done calculations that we can, just within our vulnerable communities, we can still overwhelm our healthcare system if they become really big hotspots.
So that leads us nicely into the next question I was planning on asking, but we also have a number of questions in the chat and on some of the registrations about contact tracing. So, Tomás, there's been a lot in the media about this plan that San Francisco is doing. And, can you tell us a little bit about that? Who the partners are, what you hope to achieve. Can you do it? Is there sufficient testing? Is there a sufficient workforce? What is that looking like for you guys?
So I want to tell you a little bit how that started. So, and everybody will relate to this. Remember early on, we were talking about this idea that you're going to transition from containment, which is primarily case investigation and contact tracing, isolation and quarantine. You're going to transition to mitigation, social distancing measures, etc. And that people were going to stop doing case investigation and contact tracing. That it's just too much work. And so we were about to do that. We were about to give up on it. And then, we're learning what was happening in Asia and Korea, where they have these armies of people who are doing it. And then at one point, we sort of reached this point where we realize is that a lot of decisions were happening, what I just called a scarcity mindset, that we kept dialing back our interventions based on the limited resources we had. And we started realizing, no, we have to do the opposite. We have to think big and bold, and we just have to say, this is what has to happen, and then the resources will come. And so there was this transition of going from, no, we're going to do this, even though we can't do it right now. We're going to figure out how to do this. And then somebody did some calculations based on Korea. We thought we were going to need 150 people. And at that time, we had people coming from UCSF who some were volunteers and some we hired just to join our effort. And so they were with us helping out on all of this stuff. And as we learned, we gravitated towards a vendor that had an app system that would allow you to do case investigation, contact tracing from home, from your computer, and you can train a digital workforce that can be distributed and can be doing a lot of this work. And so basically that's how it started. And I think other people, I know they started doing this in Massachusetts. The state's now going to do it. So the state is hiring a vendor, and they're going to roll this out across California. They're hiring UCSF and UCLA to do the training based on the experiences that we have here. And I think it'll work. It's going to work for, I think, an average person who you can, over the phone, you can do all this. The big gap for me is going to be really these vulnerable populations that really need boots on the ground. You need people in the community to be doing this kind of work. It's a different strategy. They complement each other, and I think both are important.
Sara?
And so our team here has been working very closely with Tomás's team, using the same app and the same model and trying to scale as well in Santa Clara County. And I think sort of similar to Tomás's comment, we need to complement that with very carefully thought out surveillance systems, because it may be that the general level of community transmission is low, but we have places where there, may be intense foci of transmission, and we have to have surveillance systems in place to detect those early. One of the things I was thinking about is, I don't remember whether this was shared, but early on when we were doing very careful case and contact investigations with the help of a CDC team that was embedded in our emergency operations center, and we learned everything we could about every single case and looked for patterns, et cetera, et cetera. And early on, we found a cluster of cases among people who worked at San Jose International Airport. There were 4 TSA workers, as well as I think a food worker and someone who did transportation, et cetera. And the initial way that it played in the news was, we need to know about this because we, the public, are being exposed to these workers in the airport. when actually it was quite the opposite. We need to worry about the workers who are having intense exposures to the public. They're really serving as sentinels in a way to let us understand what level of community transmission. And of course, these are the workers that see the people on departing flights. So I think their infections really were an early signal of the level of community transmission that we had in our community. And then, you know, as they're funneled into an airport, we see sentinels of, you know, the TSA workers who are exposed to so many people again and again. So that's just kind of by way of saying, yes, we still need to think about where are the places in our community, particularly like what workers are having more intense contact with the public, and how do we ensure that we are screening them frequently, both for their own health and in case they need to isolate, as well as using that information to help understand transmission patterns and where we really need to lean in and do more.
So we had a question that somebody put in when they registered that sort of goes along these lines. As you continue to prepare to reopen, I always have to use air quotes when I use that phrase. You know, it would be helpful to know and share with the community current transition patterns. For example, do you see recent cases among people who, you know, have only gone to the grocery store? And, you know, if you do, what does that suggest? If you don't, you know, what does that suggest? What other actions would you need to take? And are you sort of now in an ability to gather that information and react, you know, as new hotspots pop up?
You're asking a really good question, and we were just talking about. What's that?
It was somebody else's question.
We were just talking about this yesterday. We have a research team that meets once a week just to talk about some of these issues. And I'll tell you, one of my challenges is that we've been just so overwhelmed that we haven't even done a basic really good descriptive epidemiology of you know, like the first 1,000 cases. There's issues with the data quality. There's gaps in information about different risk factors like homelessness and race ethnicity. We haven't done a basic case control study just to really quantify the different risks. And yesterday we were talking about how can we improve our data system so that we can do a prospective case control study. So there's actually a lot of, you're bringing up really good questions. So a lot of it ends up being intuitive because of what comes across, but we haven't done it systematically. And I think, so I would say that's a gap area for us that we have to get better at.
Sarah, do you have anything to add on that?
Well, I would concur, and you know, speaking, I love hearing what Tomás has to say about how they're thinking about this. My challenge with this whole response has been trying to keep up with the literature, trying to keep up with the epidemiology, and think ahead to what the questions are and what information we need to take what public health action. At the same time that we're trying to manage like the huge volume of communication to translate what we're doing to the public and to many stakeholders, and just to manage the political environment. You know, it's the classic trying to drink from a fire hose, but for like week after week after week after week. So that's why that's why I love Tomás. That's why.
And I love Sarah. She's teaching me a huge amount. And something that I've noticed with this epidemic is that a lot of conventional wisdom we had to throw out the window. And if we just think of early on and how we talked about this epidemic, you know, when we compared it to the SARS-1 and we compared it to other coronaviruses, and, you know, no, asymptomatic transmission is not a driver of this. I can remember all of us talking about this with all this conventional wisdom, and it was all wrong.
I know.
And I think, so it's really been it's been a humongous learning opportunity for all of us. And I think recognizing that there's a lot we don't know, I think you try to design stuff that takes that into account. And that's why I've been Sarah, I don't know if Sarah knows, Sarah may not know. I think before we did the March 16th thing, I had brought up on a meeting that we had this idea of universal masking. So I had been promoting this idea over and over and over again, and people could not imagine us doing this. And eventually it's happened. And then it's one of these things where we're just sort of thinking about what are we missing? What can be happening here? And asymptomatic was just this unknown. And so what can we do about it? And it's just applying basic infection control principles like source control. It's not perfect, but if you can prevent big droplets from coming out, and but anyway, and I think we're because we're operating with these big knowledge gaps, we're sort of implementing strategies that take into account some of those areas. But it's been a very humbling experience for all of us.
So for sure, and this is so much fun. I'm just thinking about a couple things. We had, when we were in our smaller operations center, we had these giant Post-its that we had on the wall, and we had one that was entitled Unanswered Questions. And we were just sort of keeping our running list about the basic epidemiology that we didn't understand. And number one on the list was asymptomatic transmission, ? Magnitude, ? Because that uncertainty drives so many of our decisions. And I was also thinking, I'm sort of like the last person who has really embraced the masks. And here's why I was stuck. I was stuck by the reality about the PPE shortage and not wanting to tell people to do something that they couldn't actually implement, when actually there's like a really simple solution, which is homemade face coverings. So we all get stuck in different places. And again, that's just the value of having a collaborative where you can work through all the unknown.
So, we have a couple sort of really tactical questions. So, are you guys using a particular app or other technology pieces in your contact tracing? Folks want to know. The public wants to know.
We're using what San Francisco's using, and Tomás, do you want to describe?
Yeah, it's I guess it's a ComCare app from Demagi. It's from Demagi, and I know it is using open source programming, and I know Demagi has worked with the CDC and has been doing this on the East Coast. The California Department of Public Health is going to be developing a different solution. I think they're going to be taking the same model, but they're going to be Governor Newsom had mentioned at his press conference yesterday that it's going to be a Accenture, Salesforce, and Amazon. Yeah. So we don't know if that's been built. I know they're going to be pilot testing it. So we'll have to see how this all comes together.
So we have a couple questions about, again, this idea of reopening. And somebody in particular who says they're a Santa Clara County native and his or her parents still live there. People are getting antsy. This is not unique to this person's parents, right? Wanting to go out and socialize. So how do you communicate to these people about, maybe the rules are relaxing a little bit, but that doesn't mean you can go all in, and sort of what'll be changing in the coming months? And, clearly you can't get too far ahead, but, what are sort of some of the factors that you're thinking about, and what are you trying to communicate to the public on that?
So here's how we're thinking about it. We want to proceed with reopening in a gradual way. We don't want to take steps that are too big and get ourselves into trouble. We want to take small measured steps and then measure how we're doing. And so we have a new shelter-in-place order that went into effect in the Bay Area region on Monday. And there's a number of activities that were not allowed before that are allowed now, and that includes construction and outdoor businesses. So all the landscapers and gardeners and nurseries that were not open before are now open. But the challenge is it takes a good 2-3 weeks to see what the impact that has on community transmission, and to understand what level of risk that created or didn't create. But in the meantime, you know, all of us are feeling incredibly antsy, and our local economy is really struggling. And so for me, what keeps me up at night and makes me incredibly anxious is that I want a much more refined understanding of the trade-offs that I'm making. You know, this whole event has been about making the best decisions that you can with the best available information that you have, and it's always incomplete. And so I think I need to spend a little bit more time on the RAND link that you sent out to all of us, but just getting everyone together to help think through these trade-offs, because we know that there are health impacts in the short, medium, and long term for the economic and social devastation that we see all around us. And we also know that if we relax too fast or too soon, that more people are going to die. You know, there's just no way around it. More people will die, and there's many people in our community who are not able to social distance because of the structure of the household and the neighborhood where they live. And if we collectively in public health don't, you know, decrease transmission as much as we can, those are the people that are most at risk and that are going to die. And they're also probably most at risk from the economic disruption that is caused. So it's really, really, really hard to try to keep those two forces balanced. And so we just want to just gingerly chart the course forward. We in the Bay Area came up with some indicators that we're following to help us inform the steps that we're taking and to help the public see what we're doing. And Tomás and is working, his team is leading a group of epidemiologists from around the Bay Area that come up with regional indicators. But just sort of in generalities, we're looking at just the basic epi-trends, you know, the number of cases that are reported, which of course will change with increased testing, the number of hospitalizations, which is a solid indicator, but it lags. We're also still measuring our hospital capacity, as well as the amount of personal protective equipment. So if we did have a surge, would we be able to manage it? And then we are looking at really the response capacity, which has to do with the lab capacity and the scaling of case and contact investigation. So that's what we're looking at, and I just want to acknowledge for everyone what we're all feeling, which is that this is just extraordinarily difficult, and it is not going to get easier. It is not going to get easier, and so we just have to dig deep to whatever resources we have to take us day by day.
So I want to, yeah, thank you very much. That was a really good summary. And I completely agree with that. And I think one thing to realize is that what ends up happening, just like Sara mentioned, is that the low-income communities and communities of color are the ones that really get the brunt of this at every level. The other thing that I'm finding really useful, so we had a biostatistical epidemiology team at UC Berkeley School of Public Health develop a very interesting model for us, because what they do is that it's all based on your hospitalizations. They realize that the most stable measure that we have right now is hospitalizations. The state is collecting this information from all the hospitals across the state. And what it does is that it takes what we know about the transmission dynamics of the virus, and you can tweak those. It takes your local hospitalization data, and then it projects out what your expected hospitalizations are for short-term and long-term, and it also does an estimation of what your R effective reproductive number is. And for San Francisco, they have validated, it's actually pretty accurate. It's been able to predict very well where our hospitalizations are. And right now, our effective R0 is just below 1. And so this is open source. Anybody can go in there and tweak it, and you don't actually, and you can run it from Microsoft Excel. And so one of our analysts did some was testing some scenarios. And if our effective reproductive number goes up to about 1.3, it will explode. And this is where it's really scary. When you start going even a little bit above 1.3, and we know that this virus, its basic reproductive number is probably 2.5 to up to 3.5. This thing is so infectious. So we're talking just a little bit. It could overwhelm our hospital system easily. And I think for us, we're looking at this and we're saying, oh no. So it's very sobering when we see this. And I think for us, it becomes a communication tool to help policymakers realize we've achieved a tremendous amount. However, when we go forward, we really have to proceed cautiously. We have to have all these systems in place. There's a tremendous amount of work that needs to be done, because otherwise, Sarah's correct. One of the things the model shows is that when you implement an intervention, it's at least 2 weeks before you start seeing its impact. And what happens is that you think in those 2 weeks, you have this big iceberg of invisible infections that have now occurred, and you cannot uninfect people. Once you have this humongous iceberg that you cannot see of infections, that iceberg is just going to rise up, and you're going to have all these hospitalizations and deaths. And that's what's so frightening about this, is that you can't see it, and it's so lagged. And so it's just that reinforces the importance of us developing really, really robust surveillance systems. And so we're thinking about, right now, today, we're talking about how can we require testing, mandatory testing of the workforce, because right now it's voluntary. We're encouraging people, but there's a disincentive to get tested, because if you don't have symptoms, you don't want to be isolated. You don't want to be a close contact because you're going to be quarantined. So there's this built-in disincentive to get tested. So we're actually thinking about how we might make it mandatory, because we're going to do case finding, but it's also going to become our surveillance system. And so these are really, really difficult questions that we're trying to figure out, but these tools help extend our intuition so that hopefully we can not get ourselves in trouble.
So you mentioned a little bit about how tools help you in your discussions with policymakers, and we have a question asking about political dynamics and the interaction or maybe tension or not between elected officials and good public health guidance. You guys want to share any public observations on those situations, which I know are not easy?
Go ahead, Sarah, and then I'll follow you.
Okay, I'll start. So just for those on the phone that aren't from California, the way that things are structured in most counties, and Tomás is an exception as a city and county, but as a county, where my electeds are 5 board of supervisors, and so the supervisors each represent a particular part of the county. And our big city, which is the city of San Jose, represents more than half the population, but I'm the health officer, and we're the health department, and the county provides all the health and social services for all of the cities in the county. So I think this has actually been, challenging in some ways, and maybe a relief in other ways, in that the health officer, we're making the decisions based on public health from a pretty pure public health lens, which has been challenging for the politicians, because they, in other decisions, they're the policymakers. They're to be making the policy, which we carry out. And so this is, I think this has been challenging in that way. I feel that they've been very supportive. They have a lot of questions, and they are in a tough spot, because they are the ones that are fielding a lot of questions from constituents, both those that are happy with what's happening and those that are not happy with what's happening. But at the end of the day, because of the way that the laws are structured here, the health officer, I am making the decisions regarding the shelter in place and how strict it is and when to lift it. So I feel for them. I think they're in a tough spot. On the other hand, in a way, it's when they get in a tough spot, they can say, I'm not making the decision. It's the health officer. And so maybe that's helpful for them.
So San Francisco is a city and a county. So we have the health department is under the mayor, and we have 11 board of supervisors. So so basically it's like having Washington D.C. in San Francisco, because we have our legislators and we have our executive branch. I feel very fortunate. I think for me it's been nothing but positive. San Francisco, the politics is very in your face because everybody, you know, we're so everything is small and close, and people can just walk into the health department, just knock on my office. People call me up all the time. Everybody is very accessible. So it's very intense. But we have had, I've been just very surprised. And I can remember distinctly the call we had when we told Mayor London Breed that the health officers wanted to shut down the Bay Area. And on the call, there were people that were, you know, what, you know, you can sense this resistance. And the mayor says, you know what, if we have to go. I was so impressed. She just stepped right into it. And she says, you know what, these counties are asking for our support. And if it were reversed, we'd want them to support us. And it's like, she was just on board like this. And then all of a sudden there was everybody just got behind her. And I think for me, it's been fantastic. So the board of supervisors, the mayor, it's been very, very supportive. So I feel lucky because I read the newspapers, and I know that in other parts of the country, they haven't had that benefit, that there's been tension between the political, but also tension between the public health and the political leadership. We've been fortunate in San Francisco.
So we have a question about vaccines and sort of opening and closing, if you will. So there's been talk about a second wave, maybe in the fall, maybe, you know, in January 2021. Is it realistic that we're going to have a vaccine by January 2021? Are we going to do this constant open and close until we have a vaccine? Again, you guys don't have crystal balls, but you know, what's your thinking on those topics?
Sarah has a crystal ball.
Can you share it?
I'm looking at it right now. I think a vaccine's a long way off, and so we're going to be relying on our traditional public health tools for a long time, and so that's going to mean setting up solid, creative, sustainable surveillance systems, maintaining case and contact investigation at scale, and continuing to communicate with the public so that they understand what's going on and why. You know, the why, it's really hard to communicate, and we're going to have to. I'm afraid that this is really much more like an ultra marathon. That's my sense.
I agree with you. I mean, I think treatment hopefully is right around the corner as people do randomized controlled trials with different therapeutics. So for me, we're planning for the long haul, and I would say the key thing that we're going to need, the biggest tool, is going to be testing. We need home testing, saliva testing. We need it to be so easy, so ubiquitous, so everybody can really know their status, because that's what it's going to take with the amount of asymptomatic transmission, which is really, really large. So I would say we have to plan for the long term and really build up our testing capacity.
So, we talked a little bit about some of the racial and ethnicity disparities and some of the underlying conditions. Another easy topic, there's been discussion about some of the social determinants of health, that ubiquitous thing that the vast majority of the public don't really know what we're talking about, but all of the community conditions that, you know, affect people's health. And so, you know, compounding the racial and ethnic disparities are also that, you know, people of color are more likely to live in less safe neighborhoods, less healthy neighborhoods, so on and so forth, have underlying conditions. I on my more optimistic days, am hoping that this is a way for us as a field to talk about all these things and, you know, to have sort of, unfortunately, some concrete evidence about, you know, all the things we've been saying about unhealthy communities are coming home to roost. I don't know if you guys, that's not really a question, but if, you know, as you're thinking about sort of the response and the follow-up, you know, how do we continue to raise awareness of these issues that are not just about infectious disease, but, you know, sort of our everyday goal to keep people healthy and safe?
So I can, yeah, so for me, the equity and the racial equity issue is really important. And this is a continuation of the kinds of discussions we've already had in big cities about how do we activate, operationalize equity and racial equity. So it happens at different levels. One level is within our departmental operations center. So we have an equity office. So there's this whole effort in our emergency operations center, where we make sure that people are taking into account equity as they roll out policies to remind people of the impacts. We still have a lot more work to do, and I think this is where I realize even though we have this a certain amount of consciousness, sometimes I do see. So an example that I'll give you an example that I hear that bothers me. So people who are promoting the herd immunity approach through natural infection, which is just let the communities, let it move through a community, right? Let the infection move through the community. It's going to build herd immunity and we're going to be better off. And when you really think about that, it's going to, for all the reasons you just mentioned about the disparities and how this epidemic is amplifying all the inequities that we have, you're going to build herd immunity. You're going to build herd immunity primarily through the people who are not only the most likely to get infected, but the most likely to have adverse outcomes when you think of the chronic medical conditions, the obesity, diabetes, all of that. And so, and meanwhile, the people who are able to protect themselves are just going to wait for the vaccine to become available, or they're going to have access to easy testing so that they can manage their risk. And so it really bothers me when I hear people talk that way about just, and you hear this even at the international in terms of developing countries, that's the people are promoting this strategy. Oh, just let it move through the population, not really taking into account that it's gonna devastate them. All those deaths means that there's gonna be kids without parents, families without grandparents. It's going to worsen the economy. It's going to be, remember, this is going to amplify the inequities. It's not going to solve them. It's going to amplify them. So what I'm hoping comes out of this is that people begin to see some of the contradictions, some of the contradictions of policies that for example, just universal health care that depends on employment. When you have a pandemic and you don't have a job, guess what? You now do not have health insurance. And so we need a way to really have universal health care for everybody that doesn't depend on somebody having to have a job to have health care. So these contradictions, I'm hoping we begin to address these systematically, because everybody across the country recognizes how we all have a shared, we're all in this together. So hopefully things will become better. And actually public health, it's like finally people understand, our CFO finally understands public health. It's like, it's so concrete. They kind of realize, wow, it's so much cheaper to do this and to prevent a surge than it is to have to deal with a surge, which would have cost infinitely more money.
Yeah.
Completely concur on all points. I would, someone popped in, we're having this discussion the other day about sort of like societal changes after World War I, World War II, you know, the Great Depression, sort of like these major social movements, and trying to think about like what are the big changes that we're going to see after this pandemic, you know, is finally over, if it's ever over. And I hope that one of the things that we see is some lasting understanding of public health, because this epidemic and this experience has really just kind of like, you can see the what our policies and investments have revealed, and you know, the very thin public health infrastructure has been super problematic, and you know, maybe when this is all said and done, we will be doing a little bit more investment in public health and won't need to invest quite so much in the healthcare delivery system. I don't know, but I remain hopeful. Similar to Tomás's experience in San Francisco, we have our Office of Racial and Health Equity. The entire office has been moved kind of en bloc into the management section of our Emergency Operations Center, because everyone recognized how critically important it is to have an equity perspective in all of the decisions around communication, around strategy, and around operationalizing all the different scopes of work. And I don't think that wouldn't have happened. So to me, it's been actually lovely to see the public health work embraced by so many different sectors of our county government, and with a much deeper understanding of what public health brings. That's been rewarding.
Good. So thank you guys. This has been amazing. We are going to bring up a slide to let folks know that this is the first in a series of exciting Big Cities Health Coalition webinars. Our next one, while it's loading, is 2 weeks from today with Patty Hayes from Seattle King County. And then in the first week in June, there we go. Now I don't have to do it from memory. Thanks, Gabby. The first week in June, we'll have Oxides Barbeau from New York City. And then in the middle of June, Muntu Davis from LA County. So on the next slide that Gabby's going to move to, you'll see how to our website address and how to sign up for our newsletter so that you can make sure that you get these announcements. And today's webinar will also be on our website. So Sara, Tomás, thank you so much for A, taking the time, and B, launching this with us. We really appreciate it. Thank you for all you do. It was fabulous to see your faces also. And we will end it there. Thanks so much.
Thank you. Bye, everybody.
Thank you. Bye.
Bye.
Stay healthy.
Bye.